Very good morning. We'll continue our class with mycology. Today we'll discuss a component about the in mycology where you have to we discuss about the opportunistic mycosis. Now, as this term implies, these are basically infections which normally do not occur in a person or a host who is immunocompetent. So these are the infections which usually occur in patients who are immunocompromised by virtue of certain physiological conditions, or maybe because of chemotherapy, or maybe because of certain malignancies, or sometimes because of certain immunodeficiency conditions which are because of genetic preponderance. So the infections, the mycotic infections which cause this entity which we call as opportunistic mycosis, there are very many of them are there. So we'll go into detail one by one. So this is a picture. I think most of you would have seen this picture. If you're familiar, if you have remembered that this is basically the candida species, which again is a very important component of which contributes to opportunistic mycosis. Then we have the other molds, which is, if you again remember this, recollect this picture, this is basically aspergillus. So we have varieties of aspergillus, the molds, which can cause opportunistic infections. Then we have the other yeast, which is known as Cryptococcus neoformans. This is again a very important entity which cause opportunistic mycosis, sometimes leading to life-threatening conditions. So these are, as I've already mentioned, they are produced by relatively non-pathogenic or contaminant fungi and hosts whose immunological defense mechanisms are weakened because of either endogenous or exogenous causes. And it has been observed that these group of mycoses, they can cause a lot of morbidity, mortality in hospitalized patients. So the types you can classify, these are the mycoses, which basically means the infections. You can have candidiasis, cryptococcus, aspergillosis, zygomycosis or mucormycosis, which are caused by the zygomyces. Then you have pneumocystosis, penicillosis, and certain other opportunistic, miscellaneous opportunistic mycosis. Now, candidiasis is a very common infection, opportunistic infection, which is very often observed in immunocompromised hosts. The old term which we refer when we talk about candidiasis is moniliasis. So this is a yeast-like fungi, and it has been observed that in certain individuals you can have this mole or this yeast as a part of a normal flora, which can be there in the skin or even in the oral mucosa, sometimes in the basically in the sometimes in the gastrointestinal tract. But the infections, when it happens in immunocompromised individuals, can affect the skin, it can affect the internal organs. And so this is, as I've already mentioned, that it is one of the currently important cause of opportunistic fungal infection. So there are many species of candida which are known to cause infections. Most of you must be familiar with Candida albicans, but over the years we have seen that there are other species of candida which have caused a lot of opportunistic infections in immunocompromised individuals. You have Candida tropicalis, Paropsilosis, Kefir, Glebdata, Cruce, Guillermondi, and Lusitani. This is just to name a few of the Candida species which are known to cause human infections. So this group, we have a term which we call as non-albicans Candida, because we know about Candida albicans. So these other groups which are not albicans are referred to as non-albicans Candida. So these are the infections which normally it can cause. It can cause infections in the oral cavity. You can have the oral thrush. Then it can affect the vagina. It can affect the nails, where you can have onychomycosis. Sometimes it can cause dermatitis. In children, it is also a common cause of diaper rash. So these are some of the infections where the candida can cause affecting the cutaneous as well as the subcutaneous tissues. Then, regarding the systematic infections, more importantly, here we have esophagitis. Now, esophagitis is a very common presentation, especially which you see in patient with HIV infection, because this has been used as a criteria where you define as a AIDS defining illness. So if you have a patient who's HIV positive and if he's not on the ART, very often they will present you with dysphagia, which when you do an endoscopy, if you examine the gastrointestinal tract, you will observe esophagitis. So this is one of the AIDS defining illness. If you have a patient with these presentation, then you can be sure that the patient is progressed towards AIDS. Besides these, there are other systemic infections manifestations. You can have meningitis, you can have all these kind of systemic manifestations which is seen in associated with candidiasis. Then it can also cause an entity which we call as chronic mucocutaneous candidiasis. So here again, as you've seen here, it can affect individuals with impaired cellular immunity and individuals who have got hyperparathyroidism and iron deficiency anemia. So coming to the lab diagnosis, whatever the entity is, whatever the manifestation is, there we have to diagnose this agent which cause the clinical manifestation. So most of the time, it depends on the site of where the infection has occurred. So you can take skin scrapings if it affects the cutaneous, or you can have mucosal scrapings, or sometimes if a person is having systemic infections, then you have to do blood cultures, as well as the sites. If it involves a sterile site, then you have to take the relevant body fluids. So what is done in the lab is that we usually do a microscopic examination. Here you will see that the yeast can be observed on gram stain. Very simple gram stain is sufficient to at least identify or observe the agent which caused the infection. You will observe when you do gram stain that the yeast cells are usually gram positive. So these are the budding yeast cells. As you can see in this picture, these are the hyphae which is observed on a gram stain. Now, besides the gram stain, you can also go for cultures. So we know that Sabot's dextrose agar is one of the primary culture media which we use for routine isolation of the culture. So this is a colony which we observe in case of Candida. It's usually creamy white. Sometimes it can be mucoid colonies. So after we observe these colonies, we have to identify, because if you remember the previous slide, I've mentioned that there are many species of Candida. So just by looking at the colony, you will not be able to differentiate what species of the Candida it is. So you have to go for identification. So for identification, there are many methods which you can go for identification of the species. You can go for assimilation, sugar fermentation, or we can put something which we call as a cornmeal agar. So this is a media which actually helps the sporulation of the yeast, where you can observe the spores, or what you can call chlamydospores in the case of Candida. You can observe the chlamydospores. So each of these species of Candida will show very typical pattern of typical morphology on cornmeal agar. Serology is there, but again, it is not very helpful. There have been a lot of serological tests wherein we look for the antigen, usually mannan, because this is a primary component of the cell wall of the Candida. So mannan, galactomannan, these are some of the antigens which have been used as a mode of diagnosis, where you can look for these antigen in the clinical sample of a patient. Besides that, we also have what we call as the PCR methods, but these are not routinely used. So the mainstay of diagnosis is we still rely on microscopy and culture, particularly when you talk about cornmeal agar. Now, to differentiate between Candida albicans and the other species, there's a test which we call as a germ tube test. Now, this is a very simple test. You just have to take the isolate and then put it in serum, incubate it for maybe 2 hours, and then you look for the germ tube. So this is a picture here. You can see these are called as the germ tube. So in case of Candida albicans, you will see that the germ tube will be positive. So this is again one way to differentiate. Easily you can differentiate between Candida albicans and the other species of Candida. Now, cryptococcuses. Now, this is a fungus, fungal infection which is caused by an encapsulated yeast. So this is called as Cryptococcus uniformans, and it has been found to be pathogenic to both man and animals. So after candidiasis, you can have Cryptococcus, which is the second most common fungal infections, which particularly affects patients who are either HIV infected or even otherwise immunocompromised by some other causes. And this fungus usually naturally it also occurs in pigeon nest droppings and old buildings and nitrogenous soil. So it is also there in the environment. So that is how usually the immunocompromised individuals acquire the infection, because this is ubiquitous in nature. So easily a person who's immunocompromised can acquire the infection. So this is a pigeon where the reservoir of the fungus. Then we also have some vegetations which we call as the river red gum tree, or like in India we have commonly we have eucalyptus trees. So eucalyptus trees are also the common source of a reservoir of the fungus, where it can be present in these vegetations. So there are four serotypes and 3 varieties. If you see here, we have the Cryptococcus uniformans A, B, C, and D. So each of these have been, again, the varieties can be Cryptococcus uniformans var uniformans, or we can have Cryptococcus uniformans variety Getty, and we can have Cryptococcus uniformans var grubi. So these are the varieties of Cryptococcus uniformans. But predominantly here, if you look at the infections, most of the infections are usually caused by Cryptococcus uniformans var uniformans. So this is usually how the infection is acquired, because this is present, I told you, in the environment. It can be present in pigeon or bird droppings. So these the yeast itself, it exists as spores. So a person who is immunocompromised, when they inhale the spores, what happens because of the favorable pH and humidity in the lungs, it becomes encapsulated. So the spores themselves turn into the yeast, and then from there it can cause the infection. If a person is immunocompromised, then it can lead to dissemination of the fungus. It has an affinity to affect the central nervous system. So most of the time, when we what we have observed is that most of the time patients who are immunocompromised will present to you with meningitis, which will be of chronic type, which is almost similar to presentation of tuberculosis, where they can present you with chronic meningitis. This is not the same as what you see in case of bacterial meningitis, where the presentation will be very acute and pyogenic type. So the virulence factor, this is a capsulated yeast. So the capsule here, this is, as you know, the presence of a capsule, it inhibits phagocytosis. So that itself is a important virulence factor. And the fact that yeast itself have got the enzyme which we call as enzyme, the phenol oxidase. So it affects the central nervous system. Commonly, where we have the basal ganglia, where you have a lot of these dopamine. So here again, usually it affects commonly those sites where dopamine is, L-dopa is present. So the clinical features, most of the time when you talk about the manifestations of the opportunistic infections in HIV especially, it is all related to the presence or to the quantity of the CD4 cells. Okay. So in case of cryptococcuses, most of the time it has been observed in individuals, HIV positive patients, when the CD4 count falls down to less than 200 cells per cubic millimeter. So extrapulmonary cryptococcuses is one of the AIDS-defining illness. That is what I was telling you about meningitis, because most of the time you might have patients who come with pulmonary cryptococcuses. It can be self-limiting in patients who are immunocompetent, but in individuals who are immunocompromised, most of the time they can present you with extrapulmonary cryptococcuses, where it affects the central nervous system, the viscera, bone, skin, etc. So this is what I've already mentioned, that Cryptococcus meningitis, it resembles tuberculosis, because the presentation is almost same. It presents as chronic meningitis. So here again, depending on the site which it affects, you can take serum, CSF, more particular, more relevant when you're talking about meningitis or certain body fluids. If it affects the, the pleural fluid or pericardial fluid, if it affects the heart. So depending on the clinical manifestations, you have to take the relevant clinical samples. So once it comes to the lab, what we do is we do a wet mount. This is a very simple test. You just take the clinical sample and you add a drop of the India ink. Okay. So once you add the India ink, what you will be observing is the budding yeast cell, which is approximately 5 to 20 micron in size, but a very distinct halo. So this is a very rapid test you can easily do. If you have seen it once, you will not forget because the morphology is very, very characteristic. So this is again another classical example of what we talk as negative staining, because we do not actually stain the subject of the object of interest. We are not staining the yeast cell, but what we are staining is we're staining the background, and that is what you will observe. Then we can also do a gram stain. Here again, you will observe gram-positive budding yeast cells. So this is a picture. What you see is the negative staining. You can see the background because of India ink. The whole background is black in color. And you can see these are the yeast cells with the halo. This halo actually represents the capsule of the fungus. So this picture is very characteristic in case of Cryptococcuses. You will, if you've seen it, you will not forget it because it's so characteristic. Then again, culture. We can go for culture. Again, here we can have the Sabros dextrose agar. Similarly, here when you look at the colonies of Candida and Cryptococcus, it's very difficult to differentiate them because they will look almost the same. So we have a selective media which we call as birdseed agar. This is actually used if you have to, get isolated from the environment, because this particular fungus is also present in the environment. So if you have to take or if you want to isolate the particular fungus from the environment, you have to use a selective media. This you don't use it on a sterile sample. So here again, you will observe brown colored colonies due to the melanin production, which is, as I've already mentioned, because of the enzyme phenol oxidase. We also have rapid antigen tests here, which we call as the Cryptola tests. Here you can detect the antigen of the fungus in serum, CSF, and urine. This is again a very rapid and a very specific test. You can easily do this test. You can get the report within maybe within 1 to 2 minutes. So this is a rapid test where you can use for detection of the fungus in some clinical sample, because if you have to wait for culture, it will take some time. So even if your antigen, if your negative, your India ink or your India ink is inconclusive, you can go for the antigen detection, which is very rapid and very specific. So this is the birdseed agar. You can see the brown colored colonies, which is observed if you put it in a selective media, particularly the birdseed or nigroseed agar. So for treatment and prophylaxis here, antifungals, you can use amphotericin B, which is a drug of choice. There are other drugs which you can use, that is flucytosine. There are some vaccine which has been developed, but it is not as a very good vaccine which for use. Coming to aspergillosis. Now this again can cause systemic infections in both immunocompromised as well as immunocompetent individuals. And again here, because this is a mole, so when you talk about moles, you know that they can exist as spores. So the infection is usually acquired by inhalation of the conidia. Sometimes the infection can enter inside the body through direct entry, especially if unsterile equipments, instruments are used during surgery. Then the spores, because these spores can be present in the environment. So if the instrument you're using or the area where you're doing the surgery is not sterile, then that is how the spores can enter inside the body. So there are many species. We have Aspergillus niger, we have Fumigatus, Flavus, and TDs. So these are some of the important species of the genus Aspergillus which are known to cause infections. So this is how the fungal spores, when a person inhales, okay, it can go to the alveoli. This is again a very important infection which has been observed in patients who had primary tuberculosis, because What happens when you have a person has primary tuberculosis? Invariably, they will land up with cavities. Now, these cavities are empty. So, if these spores enter inside these cavities, they can form something which we call as the fungal ball. It can form a fungal ball or aspergilloma, which is often observed in patients who has recovered from tuberculosis, but can also present with that. We can also be infected with aspergillus. So the clinical types of aspergillosis, it can be pulmonary aspergillosis, and the categories of these pulmonary manifestations again will depend on the host, whether the person is immunocompromised or immunocompetent. So you can have an entity which you call as allergic aspergillosis, which can be in the form of asthma. This is usually observed in patients who are atopic individuals. Then you can have allergic bronchopulmonary aspergillosis. This is again because of repeated and heavy exposure to spores. So a person can present with breathlessness, fever, and malaise. Or sometimes you can have the obstructive aspergillosis, where you can have the aspergillus. Once the mole or the spores are inhaled, they convert into the mycelia. So these mycelia become entangled because it has germinated from the spores. They become mycelia and they can cause blockage. So it can affect even the whole segment of a lung tissue, or sometimes even the entire lobes. So sometimes here patients can just present you with productive cough, and when you examine the sputum, you will be able to observe the aspergillus hyphae. Aspergilloma, this is what I've just mentioned, that it can colonize in a pre-existing cavity, especially from a person who has recovered from tuberculosis if they have cavitary lesions in the lungs. So you can have something which you call as a fungus ball. You can see the compact, this is a stain where you see the fungal ball in the lung tissue. Then you can have invasive aspergillosis. This is again an entity which you see in patients who are very highly immunocompromised, and it can cause a lot of morbidity and mortality. It can disseminate to the kidneys as well as to the brain. Extrapulmonary aspergillosis again can infect the central nervous system. It can affect the paranasal sinuses, skin, and endocardium. Then you can have other entities which the aspergillus itself can cause infection of the eye, where you have the oculomycosis or otomycosis if it affects the ear, or you can have onychomycosis where it can affect the nails. So these are some of the manifestations, clinical types of aspergillosis. So for diagnosis, this you have to remember that this is a lab contaminant, which means because it is present everywhere in the environment. So single isolation of the sample of the fungus, you have to be very cautious in reporting. You have to be cautious because it might be a lab contaminant. So it is important that if you have isolated this fungus, you have to again re-isolate, be able to have repeat isolation of the fungus to rule it as a pathogen. So there are many samples which you can collect depending on what is the manifestations. So the easiest which we can do is, when we get a clinical sample, we just put it in a 10% KOH mode, or we can use chalcofluoride. This is again a fluorescent dye which you can use. If you have a fluorescent microscope, you can easily use the chalcofluoride and then observe the fungus in the microscope. So in KOH mount, what you will be able to observe, the characteristic feature about the aspergillus is that the hyphae will be hyaline, it will be septate, and will have acute angulation at 45 degrees branching. Okay, so this is a very characteristic picture of the aspergillus when you do a KOH mount. Now culture again here easily grows on SDA, media, that is Sabro's dextrose agar. But for identification of the species, you can use media which will induce sporulation. So you can have the Zapek dox agar, or you can use a 2% malt extract agar. So these are some of the media which we can use for identification of the species. However, if the colony has grown on a Sabro's dextrose agar, looking at the colony itself will give you an idea of what the species of the aspergillus it is. Then we have to do an LPCB mount. Just tease a bit of the culture and look under the microscope, because it will show very typical morphology. So these are some of the cultures which you will see in case of Aspergillus niger. As the term implies, you can see the colonies here are brown in color. So when you do a LPCB mount, this is a picture you will be able to observe. Similarly with Fumigatus, you can see the colonies are very characteristic, and this is the LPCB mount which we will observe. In case of Aspergillus, you can see the colonies is olive green in color. So again, when you do an LPCB mount, you can see the chains of conidia, which is again very characteristic. So looking at the colonies itself will give you an idea of what the species can be. And similarly, to confirm that, you can go for the LPCB mount and look for the morphology of the conidia, how they are arranged on the hyphae. Then we have another entity which we call as mucormycosis. Now these are basically the invasive diseases which are caused by zygomycetes. Now these zygomycetes again are ubiquitous in nature. They can be present in soil, air, and again they are very common lab contaminants. So when you talk about the reproduction of these zygomycetes, they can have both sexual as well as asexual type of reproduction. So these are the sporangium which you will observe in case of zygomycetes, and this sporangium is filled with the sporangiospores. So these are the ones which are the spores are the ones which are very highly infectious. This is what you will see when you do an LPCB mount. Okay, you can see the sporangium with the sporangiospores inside the sporangium. Mucormycosis will include the different genera, Mucor, Rhizopus, Apsidia, and Rhizomucor. And these you can easily differentiate among them based on the morphology. This has been observed, mucormycosis is an entity which usually observed in case of in diabetic patients with ketoacidosis. If a diabetic patient has uncontrolled diabetes, then very easily if they're exposed to this type of fungus, then they can easily get the infection, which is mucormycosis. So the common infections, primary infections, which most of the time we have observed is it can cause something which we call as rhinocerebral mucormycosis. And this is the one which is the most commonest type of manifestations and very highly fulminant. So it can involve the terminate bones, paranasal sinuses, sometimes the orbit, palate, and the brain. Besides that, you can also have other entity which we call as the pulmonary manifestations, cutaneous, or sometimes disseminated form of the infections involving most of the internal organs. So rhinocerebral mucormycosis, okay, this is associated with, I told you, uncontrolled diabetes, leukemia, and certain lymphomas. And what you will observe is that it can cause extensive cellulitis with tissue destruction. So this is one of the most dangerous manifestations, excuse me, which can be observed in case of diabetics. So here again, the samples will again depend on what tissue is involved. So here we can do a KOH mount where we will be able to observe irregular broad aseptate ribbon-like hyphae with right angle branching at 90 degrees, as unlike in case of Aspergillus. Aspergillus, you have septate, here it's aseptate. Okay, so that is how you can differentiate when you look at the KOH mount. And then you have the angulation is at 90 degrees as compared to 45 degrees, which you see in case of Aspergillus. We do have some special stains, histopathological stains, which we can use if we have taken biopsy of a clinical sample. You can go for hematoxylin eosin or Gomori methionine silver stain. Now, when you look at the cultures, unlike what you see in case of Candida and Cryptococcus, here the cornelis, if you observe here, it is floccose and cottony-like. So it will literally fill up the whole of the culture. If you put it in a bottle, and when you observe the colony after a few days, you will see that it is filling up the whole media which you have inoculated. So here again, to identify the various genera of the the zygomycetes, you can do an LPCB and look for the various morphology. In case of mucor, you will see the non-septate hyphae, and you can see these are the sporangiophores having the sporangium at the terminal end. So these pictures again uh, very characteristic when you look at the LPCB mound. This is Rhizopus. Again, here you can see it shows non-septate hyphae, and you can see the sporangiospores in groups. You can see they are all in groups, and you can have something which you call as rhizoids. Rhizoids are basically the roots. This you will not see in case of mucor. So Rhizopus you can differentiate by looking at this morphology, and you look for the presence of the rhizoids. This is Absidia. Here you can see, in case of Absidia, you can also have the rhizoids, but the rhizoids do not directly arise from the sporangiophore. You can see they have internodal rhizoids. So this is how you differentiate between Absidia and your Rhizopus. So this is Rhizopus. You can see the rhizoids arising directly just down below the sporangium. But in case of Absidia, you can see their rhizoids are internodal. And this is mucor. So this is a life-threatening condition. So there are 4 concomitant approaches which has to be there. First is you have to correct the underlying predisposing condition. If a person is diabetic, you have to make sure that the diabetes is controlled, and you have to do surgical debridement of the necrotizing tissue, because you cannot leave the necrotized tissue in situ, otherwise it will lead to more infection. Secondary bacterial infection can occur, so you have to do surgical debridement. Then you have to give antifungal agents, but not azoles, because they are not very ideal. So usually amphotericin B is a drug which should be given in treatment of these kind of conditions. Then penicillosis, this is again caused by the dimorphic fungi. If you know what is the definition of dimorphic fungi, this is one of them. This is Penicillium monophyly. It is an intracellular fungi. And it's the third most common AIDS-related opportunistic infection after tuberculosis and cryptococcosis. So again here, the route of transmission is by inhalation of the conidia or ingestion. People have the habits of ingesting what we call as bamboo rats. So this is again one of the modes which the infection can be transmitted, or sometimes it can occur because of direct inoculation of the skin. So this is how we can isolate. It can be there in the environment, so you can take it from the soil or even from the feces of the bamboo rats. So the reticuloendothelial system is the primary site of infection of this pathogen, and we can see some 3 histologic patterns of the disease, which can be in the form of granuloma. It can present as suppurative lesions, where a person can have multiple abscesses involving the lungs, the skin, or even subcutaneous tissues. Then you can have necrotizing type of disease, where it can have you will be observing this in case of immunocompromised patients. The clinical diagnosis is difficult, because here when you look at the clinical manifestations, it's almost very similar to what you observe in case of Histoplasma capsulatum. This is again, if you remember, is again one of the dimorphic fungi. So here, if you look at the morphology of this fungus, it is like a yeast having cross walls in the yeast cell. So most of the time you will be observing these kind of morphology in biopsy samples. In a clinical sample, you will be able to observe the yeast cells. And most often you will see that a person acquires the infection when the CD4 count is less than 50 cells per cubic millimeter. So you see, when you talk about opportunistic infections, it's not that all the opportunistic infections occur at one time. It all depends on what is the count, the CD4 count of the person. That's why you see, when you talk about HIV, opportunistic infections and HIV, it's all relevant to the CD4 count. Some of them will occur when, like in this case, you can see CD4, the infection occurs when the CD4 cell comes down to 50. Some can occur when the CD4 cell goes to 100, it's at 100, or some at 300. So it depends on how the CD4 count comes down if a person does not take ART. So for definitive diagnosis, you have to directly demonstrate the pathogen, and you can isolate the culture in the fungus in the culture. So these are some of the stains you can use. You can use the GEMSA stain in skin biopsies. You will see the septate-like yeast cells. Then you can also use PAS or GMS or immunohistochemical assays. Sometimes, because of overwhelming infections in AIDS patients, you might be able to even visualize the pathogen in the peripheral blood smears. That means that the CD4 count of the person has really come down for it to actually come to the peripheral blood smears. So this is what I was telling you. These are yeast cells. You can see this is the septation which we observe in the yeast cells. So this is very characteristic picture of the penicillium. So you can culture it from many samples. You can use subrots, dextrose agar. Even blood agar is also a good media where you can isolate the fungus. Here it produces again woolly pigmented colonies, which you can see a very bright red rose colored pigment, which can be observed on the reverse side of the media. So here, when you do an LPCB, you will be seeing this. This is the morphology LPCB now. You can see these are like brush kind of conidia. So this is a very distinct morphology of the colony, which you can see as seen in case of penicillium. You can see it's like a bottle brush. Okay, so this is very characteristic in case of penicillium. So this is the media which I was telling you. You can see this pigment. This is a diffusible pigment which can be observed in the culture of penicillium, red colored pigment, which is very characteristic. So again here, when you do when you do an LPCB, you might be able to see the plumorphic yeast cells with transverse septations, because this is a dimorphic fungi. So you can convert the fungus from the mold to the yeast form using the appropriate media. So treatment here, you can use amphotericin and itraconazole. Okay. Now pneumocystosis, this was initially was considered to be a protozoa, but now this is has been considered as a fungi, though it has some features which is almost which belongs to both sides, both as fungi and protozoa, but now we consider it as a fungi. So the old name of pneumocystis Gerovices, initially we used to know it as Pneumocystis carinii, but now this is a new name. So this is an infection which cause a clinical presentation or manifestation which we call as interstitial cell pneumonia. So it can be stained with the fungal stains like GMS. Unfortunately, you do not grow this unfungal culture media, but it requires tissue cultures or cell lines. So that is which is against it being considered as a fungus. And it is susceptible to antiprotozoan agents like pentamethene and trimethoprim sulfomethoxazole. So if you look at this again, none of the fungal agents which we know can be treated by this. So these are some of the points which are in favor and which are which are against it being considered as either as a fungi or as a protozoan. And it is insensitive to antifungals because it does not have ergosterols, which is again a very important component of the fungus. It produces chitin, which is again what you see in case of parasites. Okay. So these are some of the stages of the parasite. You can have trophozoite, cyst, and sporozoite, which you don't see in case of fungus. This is what you will see in case of protozoans. You can have trophozoite stage, you can have the cyst, and you can have the sporozoite stage. So this is again, when you look at the life cycle, this is again more in favor of it being considered as a protozoan. So this was what led to the confusion of it being initially considered as a protozoan. So the clinical manifestations here, you can have pulmonary manifestations. Most of the time they can present with non-productive cough, dyspnea, fever, and sometimes cyanosis. Now extrapulmonary manifestations, In advanced HIV infections, it will affect the lymph nodes, the bone marrow, spleen, most of the reticuloendothelial system, and in AIDS, it can affect the central nervous system, which can be a very late complication. So this is the one of the diagnostic modalities which we usually use if we have a case of atypical pneumonia or interstitial cell pneumonia. When you do an X-ray, you will see this picture of ground glass or honeycomb-like appearance, which is very characteristic finding on X-ray, on chest X-ray of feature of PCP or pneumocystis carinii pneumonia. Okay. Then here again, if you look at the CT4 count, the CT4 count here, as unlike in case of pneumocystosis, which a person can acquire the infection when the CT4 count is less than 50 here. Less than 200 will make a person more susceptible to the infection. So the clinical samples again here, because it affects the respiratory system, so most of the time these are some of the tissues which can be taken for diagnosing. So these are some of the laboratory tests which we can do. We can do a direct examination. We can use toluidine blue. We can use GMS for staining, and we will be able to observe. These are the cysts which we can see. We can see in the stain. If you take an appropriate sample, if you do a bowel sample from the site, then you might be able to visualize these pictures. Then you can also use immunofluorescence again. Your calcofluoride is another good stain which you can use to visualize these samples in the clinical sample. It cannot be cultured on fungal media. It requires tissue culture. So these are some of the cell lines which have been used for isolation of the fungus. So the drug of choice, again, we have cotrimoxazole. I think most of you must be knowing about cotrimoxazole. So this is a drug of choice which is usually given. That's why when a person is on ART, usually we also give cotrimoxazole, that is as a prophylaxis to prevent a person from acquiring this infection. So cotrimoxazole is usually also added and when a person is on the ART to prevent the person from acquiring the infection. Then there are certain other opportunistic infections with advances in medicine. There have been a lot of increase in the number of fungal infections, and some of these which are there present ubiquitous in nature are also known to cause infection. These are not very common causes, but they can cause very devastating systemic infections. And some of these fungus are Fusarium, Poecilomyces bipolaris, Curvularia, Alternaria. They can cause infections in immunocompromised, in immunocompetent individuals also, but the infection in those cases will not be as devastating. But if it occurs in immunocompromised individuals, then the infections will be very life-threatening. So oculomycosis, we'll just complete the course. Oculomycosis, this is basically a fungal infection of the eye. What we call as, it can be mycotic keratitis, where it affects the cornea. Usually this occurs when there's any trauma to the cornea. Sometimes it can happen, a person is chopping wood and then a fragment of the wood enters inside the eye. There are many other causes which can happen because of this type of infection. So you can have endophthalmitis, or you can have the infections of the ocular anorexia. So these are some of the infections which some of the agents which can cause oculomycosis. You can have Aspergillus, Fusarium, or even Candida albicans. So local treatment with amphotericin or nystatin are usually the drugs. So this is what we have observed in a case of corneal ulcer. When we do scraping, we observe, this is a picture of Aspergillus which has which was observed from the corneal scraping. Then otomycosis, this can be from the external ear, most often caused by Aspergillus. Then mycotic poisoning. I think most of you like to eat mushroom. Be very careful, because you would have read in newspapers that people are dying because of eating of mushrooms. So this is what happens. Okay. It can cause GI diseases, dermatitis, or even some of the people die because of consumption of the mushrooms. Then mycotoxicosis, this is usually caused by an aflatoxin which is produced by Aspergillus flavus when the food product gets contaminated with this fungus. So these are some of the antifungal agents. We can have a lot of antifungal agents. Probably this will be told to you more when you do your pharmacology. You'll be told about the various uh, effects or principle of how these drugs work. But just for you to be familiar, you have polyene antibiotics, okay, amphotericin B, then you have grisofulvin, which can be used. Then you have the azoles, common drugs, ketoconazole, fluconazole. So these are some of the drugs which are the antifungal drugs which are used for treatment of the various fungal infections. Then Whitfield's ointment, potassium iodide, gentian violet. I don't know whether you still prepare Whitfield's ointment in your pharmacology, but these are some of the very old drugs which I use as, which we group as miscellaneous antifungal agents. So that is all for the class.